Thank you. This is Janet England here to talk to you about immunizations in the immunocompromised host at ADVAC 2021. I would like to state at the outset that this talk is given in conjunction with Dr. Claire Ann Siegrist from Geneva, and we have worked together on this slide. I just totally appreciate her input, her ideas, and her inspiration for this talk. I also would like to say that I'm so sad that we don't get to go to the Chateau de Menton Saint Bernard together. I do miss it. I do like going to that castle. I will start by saying thanks to Claire Ann for preparing and inspiring this talk. I want to make sure everyone realizes she got the French Legion of Honor just a few short years ago at a wonderful ceremony at the ADVAC meeting in 2019. So, starting out, vaccinations in the immunocompromised host are a very interesting and actually controversial topic. I'm going to start with the take-home messages at the beginning and hopefully repeat them several times throughout this talk. Vaccinations in this type of host really have to weigh the benefits versus the risks. This is very important, and it's not all written down for every single type of patient. However, what we do know is that immunocompromised patients are most susceptible to vaccine-preventable diseases. Most vaccines are safe, even in the immunocompromised, and that is particularly true for the inactivated and conjugate vaccines. Although vaccine efficacy may be less in the immunocompromised host, it is often better preserved than expected, and some efficacy and some antibody is much better than none. And finally, I don't emphasize it enough here, don't forget the family and the surroundings. You can vaccinate the family against flu, against chickenpox, against measles, and that will be very helpful in preventing the disease in the immunocompromised host living in that setting. So here are a list of immunocompromised states that I will briefly address in a very short talk, and obviously I cannot do a complete job, but I just want you to know this is one of my patients undergoing bone marrow transplant who was not very happy about things. But if you look here, the problems can be just based on age, such as elderly, fetus, premature, neonates, infants, can be congenital immunodeficiency, HIV-1 infection, cancer, stem cell transplant, which is HSCT, solid organ transplant, and immune-mediated inflammatory diseases. There is a whole range of immunocompromised states, and some of these are iatrogenic. We do it. Some of them are just happening because of the way things are. And you have to be able to understand and know what type of immunocompromised state they have, how long is it going to last, how are we going to approach the problem of preventing disease. Worldwide, it is clear that vaccines are not optimally used for patients with limited immune competence. So there are underestimated benefits, really. Even though vaccine efficacy hasn't been proven, that's because in general, the trials haven't been done. These kids and adults are excluded from licensing trials. They're not allowed to participate. There's high risks, a small market. Frequently, the studies that are done are investigator-based clinical trials, often without a control group. Frequently, vaccines are used off-label for this purpose. And then there's this general perception that immunosuppression prevents effective vaccine-induced immune responses. And there's the fear. The risk is mainly fear of severe adverse events, fear of legal and medical issues arising. So vaccine-associated risks in immunocompromised patients, there are guidelines. The official guidelines state that no live vaccine should be given as soon as immunodeficiency is suspected. And some of these guidelines are a little old, but they are persistent. We should not be giving live vaccines to patients with immunodeficiency. So the question is, what is the evidence for this? And can that be a blanket guideline? I'd like to talk to you that we have new immunodeficiencies today that are really in my population cropping up. And one example of this, for example, is an immunotherapy with biological response modifiers and new cellular therapies such as CD19 CAR T cell therapy. This is being increasingly used now for ALL as well as AML, myelogenous leukemia, now starting with solid tumors. This is a really important advance in the treatment of immunocompromised, in the treatment of malignancies. And what you can see here is that you take T cells and blood from your patient, you do some molecular engineering to give them a chimeric antigen receptor, you grow them up in a in a bag actually, and then you infuse them into the patient. This can then result in a depletion of some of your immune cells and specifically your B cells for years and years. How are we going to treat these patients as we get more and more of these new immunodeficiencies? Well, I don't know, but we do know, looking at the problem, that these CAR T cell therapy children have new risks of infection with high rates in our setting of infection in the first 6 months following therapy, with high rates of sepsis, bacterial infections, and viral infections. I don't know how to address these issues. But one issue we could have is to have people immunized well before CAR T cell therapy. So we do say no live vaccines in immunocompromised patients, but what is the evidence? I'm going to specifically talk about the young children here. Oral polio vaccine is an important example of one reason not to give a live vaccine in patients with known immunodeficiencies. SCID patients are those with severe combined immunodeficiency. The risk of vaccine-associated paralytic polio in patients with B cell deficiencies is high, and the main risk really is persistent viral excretion and the development of immunodeficiency-related vaccine-derived polioviruses, which can be shed and spread among the population. BCG in patients with congenital immunodeficiencies is also a problem. We have multiple case reports of various immunodeficiencies, including interferon gamma and problems, those immunodeficiencies that cannot make IL-12 or 23. All of these are very important immunodeficiencies. And what we suggest is that you really need to know what type of specific immunodeficiency this is. Now, the issue is this is very difficult to ascertain at the time of birth. So of course, there in fact may be some risks of BCG in the general population. This is something that needs to be addressed, but we do think that the risk versus benefit certainly shows that the benefit is important for the benefit of giving this to newborns at the time of birth is important. So what is the risk of rotavirus vaccines in infants with SCID? Well, there are case reports of 3 here, 7 here, and it really does present with chronic diarrhea. And if this happens following rotavirus vaccine, you should look for an underlying immune deficiency. I will just say that many of the children that we have had, or several of the children we've had, have gone on for a successful bone marrow transplant, and this has not been a fatal disease. But it is something to consider. I think at this point that diseases such as severe combined immunodeficiency should be better diagnosed by early screening. Diagnosing a SCIDS disease by prolonged rotavirus shedding is not a successful way of treating or diagnosing. And in fact, SCID diseases such as this bubble boy, that is these children that are known to have no immune system and have to live in a bubble, this is a fatal disease if not treated, and we do have treatment these days such as gene therapy and stem cell transplant, and SCIDS can be readily diagnosed by a TREC assay. This is a little blood spot assay that is relatively cheap and fast and is now routinely done in most of the United States to look for presence of thymic emigrants, which means low T cells. So if we can detect SCIDS within the first week of life, then we don't have to necessarily worry about rotavirus vaccine causing problems in these type of patients. Now, another group is preterm infants. Rotavirus vaccines are safe in preterm infants, but rarely administered. Why? Well, I think there's fear. It's not because of data. There's fear, and there's fear of nosocomial transmission. Well, this fear is actually unfounded, and I think several of us have done studies. This is from a Seattle group. The Japanese have done a nice study looking at prospective studies of infants that are admitted to NICU when some of the babies in the NICU get rotavirus vaccine. During our study, 33 infants received rotavirus vaccine. We collected stools from every single baby weekly throughout 1 year, which was almost 1,200 stools. And during this time, there was no evidence of rotavirus transmission in any baby. This is leading to renewed calls for opening the administration of rotavirus vaccine in hospitals in the United States. So what is the evidence for not giving live vaccines in these high-risk young patients? Well, OPV, there's good evidence if there's B cell deficiencies. BCG, there is high risks if there's known immunodeficiencies, whether known or unknown. And rotavirus really seems to be limited to higher risks of SCID. So how can we deal with this? We can ask for family histories before we give vaccines. We can search for underlying immune deficiencies if there's complications. What about HIV? What evidence is there for using live vaccines in HIV positive patients? Um, there is so much literature here. I'm not doing justice to all the literature published, but BCG vaccine in HIV infected patients really has been shown to have enhanced risks at the time of CD4 depletion and when there's AIDS. But in infants and children and adults who have good control of their CD4 count over 200 to 500 and good control of their HIV viral load, this is not a problem. So I think this remains controversial. The World Health Organization has said no BCG if known HIV-1 infection. I think this certainly needs some evaluation, and there are many studies ongoing with many experts better than myself. What about the safety of rotavirus vaccines in HIV-infected infants? I'm giving you some data here, but I want to say that rotavirus vaccines are safe. They are effective in asymptomatic or mildly symptomatic HIV-infected infants and should be given because, again, the benefit is much greater than the risk. There have been no safety signals from South Africa in HIV-positive and HIV-negative children, and also with similar vaccine effectiveness in both groups. What about live attenuated VZV vaccine in HIV-infected patients? It has been shown that VZV vaccine is safe in HIV-positive patients if the CD4 count is greater than or equal to 15%, either before or after immune reconstitution. And varicella vaccine may be used and should be recommended in children with HIV infection. Measles vaccine. This has been a big issue, especially in my country over the past several years because we've had increasing rates of measles. But I think there's really good data showing that measles vaccine is safe in children with a CD4 count over 15%. It's safe in 6-month-old HIV-infected infants. It's safe in infected children using a meta-analysis, and it's quite safe in adults. However, there has been one case, one fatal case of a measles strain viral infection. That patient had a lower CD4 count. So I think the safety data really applies to those with CD4 positive T cells over 200 cells per microliter. So what is the evidence for HIV-1? OPV is safe. BCG, high risk. Rotavirus appears safe. VZV, MMR, safe. I haven't talked much about yellow fever. This again is a risk-benefit ratio. Depending on where you live, it may be safer to get the vaccine if you have a reasonable CD4 count. At any rate, none of these viruses are associated with worsening of HIV disease. What about cancer? Again, going through the same list of live vaccines in patients with cancer. VZV immunization in children with acute lymphoblastic leukemia is frequently results in loss of immunity after chemotherapy. So these children who get chemotherapy may need to be re-immunized against varicella following the conclusion of therapy. The American Academy of Pediatrics is very cautious about vaccination. It says only with expert guidance. The question has to do with community prevalence and the risk of serious complications. The real issue is check the immunity. Consider VZV vaccine if exposure is likely. Think about the timing. How long is this child going to be on chemotherapy? And certainly following the induction and maintenance chemotherapy, antibodies should be assessed and the child should be considered for reimmunization. What about VZV vaccines after HST? Well, we know there's a very high risk of disease of varicella and zoster after stem cell transplant, and the standard therapy is acyclovir. The current recommendation is really to give VZV vaccine 24 months after stem cell transplant if there's no GVHD, graft versus host disease, and off immunosuppression. And there's good data for that in children. There is now a new subunit Shingrix vaccine, which is not a live licensed vaccine. And that is something that we are routinely giving now to all of our adult HST patients. The problem, the study is only in adults. The risks of VZV are substantial. We need to have data for this new vaccine in children. So what is the evidence for cancerous stem cell transplant? BCG, no data, avoid it. Rotavirus, no data, but really we don't need that. There's very, very few children with cancer being treated at the times that rotavirus vaccine is encouraged. Live attenuated flu vaccine is expected to be safe. We've actually published studies on it in cancer patients, but you don't need to use it. You could be using inactivated influenza vaccine. VZV is safe under specific conditions. There's no data on MMR. It is recommended at over 2 years following stem cell transplant. And again, no data for yellow fever. What about solid organ transplant patients? There are official recommendations for the use of live vaccines in organ transplant patients. And this is a problem because these individuals are often on immunosuppressive regimens for the rest of their life. And if, as this little girl, patient of Dr. Seacrest, who got a liver transplant, what are you going to do with vaccines that these children need to face in the regular world? Varicella, MMR, these are really important. Now, for things such as oral polio, typhoid fever, we can use inactivated vaccines, so you should not use those. Yellow fever, we can discourage travel to areas where this is a problem. Flu vaccine, live attenuated, you don't have to give it, so those aren't a problem. But for varicella and measles, these are actually really problematic. And I think the varicella vaccine question has been more studied and has more data. So varicella zoster vaccine immunization with the live attenuated vaccine in pediatric patients has been studied in all types of pediatric transplant patients in the US, Europe, and Japan. And it really seems to be relatively safe if you pick the appropriate population, the appropriate person. And with VZV infection, if there is a rash or disease following vaccine, at least you can use acyclovir to treat it. What should we do about measles resurgence? This is really a bigger problem, especially as the measles resurgence is happening throughout the world, at least pre-COVID, in both developed and developing countries. And it's such a rapidly spreading respiratory viral disease that it's very difficult. So the official guidelines recommend against MMR following solid organ transplant or hepatic or bone marrow or hepatocellular transplant. So what we would like to do for SOT is give MMR pre-transplant. But what about young infants who really don't respond well to MMR? If you're doing a liver transplant in a 3-month-old infant, what are you going to do? So the question remains, is there a subset of some of these patients, especially these SOT patients, for whom we could consider measles vaccine? There's no study I know about. We and others are considering MMR vaccine now in light of the measles epidemic, in terms of considering what about stable subjects who are 5 years post-transplant, they have good CD4 counts, they're on no rejection, they have no graft versus host, and they're only on one immunosuppressive drug. This is my opinion. This is not anybody's official opinion. I say consider MMR, evaluate the risk versus benefit, discuss it with the family, and then potentially go ahead. So I would just like to say, I work very closely with Paul Carpenter, a bone marrow transplant expert, and we vaccinate our blood and bone marrow transplant recipients regularly, often, and with lots of different vaccines. And we have written this this question and answer article about how I vaccinate blood and marrow transplant recipients, published several years ago. And I just want to say this might answer some of your questions if you deal with this population. So the first question is, when should vaccinations begin? This is a hugely controversial area. There's consensus guidelines by multiple societies. They should begin around 3 to 6 months, but it really depends on what's going on with the patient. What is their engraftment status? What is their immune status? What is their drugs that they're on? How are they doing generally? And what vaccines are you considering? Because of course we can give conjugate vaccines much earlier than anything like a live vaccine. What about flu vaccine for transplant recipients? How soon after bone marrow transplant can I give the flu shot? Well, most of us would say at least at 6 months, but if there's a bad flu year coming up, what harm is there in giving a flu vaccine at 3 months? It may not work. What we do think is you probably need 2 doses in many of these kids. There's an ongoing study comparing high-dose flu vaccine with regular quadrivalent flu vaccine in adults and children, sponsored by the NIH. The study is now completed and we're waiting on results. The bottom line is that we know in an unblinded fashion that children who are vaccinated following bone marrow transplant, who are vaccinated after 6 months do better than those who are vaccinated before 6 months. But what we don't know yet is if there's a vaccine that would be better than the other. So what evidence for SOT do we have? We have no data for BCG rotavirus, minimal data for LAIV, and you don't need to use it. VZV is probably safe. We think it's safe under certain conditions. MMR has limited data. And yellow fever, there's really limited data, and it really probably should be avoided as possible. What we do have data on is that there is no trigger of graft rejection with any vaccines that have been studied to date. Now, what about finally our last broad category of IMID patients? These are patients who have immunological disease that are treated often with high rates of immunological response modifiers, steroids, and other immunosuppressors. What about varicella immunization? One prospective study that I can find with no severe adverse events. Of course, as I said, we can treat varicella, and we can choose our time of immunization when they're not having a severe disease. What about MMR immunization? That has been a huge issue for my site over these past 2 years. It looks like there are no safety issues to date, but I think one has to be careful and consider the patient individually and potentially consider this at a time when the patient is already in a remission or at a low level of immunomodulators. What we do know is for immune-mediated inflammatory diseases, there's no significant trigger of exacerbations. So these vaccines can be given. The inactivated vaccines can be given readily. Some of them may have some response, and we think that the conjugate vaccines really seem to do the best. So to review, the vaccinations in the immunocompromised host, there's underestimated benefits, there's exaggerated fears of adverse events, and if vaccines are safe, even partial efficacy is superior to no efficacy, which is what happens when you give no immunizations. Our current guidelines contraindicating live vaccines are largely not evidence-based. We have many new immunosuppressive therapies, and I don't have time to go into them. This is just a basic snapshot. We have new kinds of immunosuppressive agents targeting early stages of T cells, these drugs, cyclosporin, alemtuzumab, all kinds of receptor antagonists, and then other agents targeting later stages of T cell differentiation. Tocilizumab is like it's the common drug of the day. We see it in so many people for all kinds of diseases. So what are we going to do with our patients who are receiving these drugs? Well, it's very tricky, but I do think we have to be smart and think about this. The influence of new drugs on vaccine responses in patients who are maintained for years, maybe forever on these drugs, really is important. You need to assess the drug they're on. There's distinct mechanisms, distinct impacts, there's dose effects, and many people are on combination drugs. And finally, there's few studies with often contradictory results, with small groups of heterogeneous patients, and variability in results. It's very, very tricky. And yet patients are going to be on this forever. What are we going to do? Well, we need more studies. There are 3 main challenges in immunocompromised patients, I think. Clarion and I think. We need to maximize the expected benefits for each individual patient. Number 2, we need to implement interventions to increase the proportion of patients who can benefit from this. And then 3, and this is for this group, contribute to update our missing or largely empirical policies. We need research, we need interventions. Who can we give this for? What are we going to do with our Crohn's disease patients who are on lifelong severe immunosuppression? This is really important. So if you are the vaccinologist on call, or the advisor to the vaccinologist on call, or the public health person who's advising the vaccinologist on call, I think there's some important caveats here. First of all, and very important, do not assume anyone's going to call you. Patients, families, doctors, nurses, they don't maybe care. They are awfully busy. They're doing their own thing. It's up to us to reach out to these people, to reach out to patients, families, doctors, nurses. Establish yourself into the medical care at your hospital or institution. For example, institute pre-transplant visits for the subject and their family. Every single bone marrow transplant patient at our institution receives a pre-transplant visit from infectious diseases, including a review of vaccines for the family and the patient. And I think this is important. We can get the family to get the parents to get their pertussis vaccine, the whole family to get their flu vaccine. Then, once you've made a recommendation, check the status. Just because you make a recommendation doesn't mean things are going to happen. In fact, they often don't. Were the vaccines actually given? That's a really important point. Do not assume that immunizations are effective, especially in an immunocompromised host. Check for vaccine induced immunity. Keep up to date on new vaccines. Think about COVID-19 vaccines. What should we be doing for our patients with these vaccines? Which of these vaccines would you want to give to your patients if you had choices, which sometimes we don't have choices? And finally, keep on boosting. This is how we are most effective. We absolutely need to check our immune responses, redose, keep on boosting. This is how we are most effective. With that, I'd like to thank Claire Ann one more time, thank the organizers of this whole meeting, and am open to questions. Thank you.